Good morning, everyone, and good afternoon, wherever you might be. My name is Robert Hamilton. I am the co-founder and chief scientific officer of NovaSignal, and I'm extremely excited to introduce our speakers for our next installment of our webinar series. Today, we'll be talking about the applications of transcranial Doppler within the neurointensive care unit. And again, I'm thrilled to announce and introduce our speakers for today. First, Dr. Katarina Korik, who is the head of neurosonology at the Kepler University Hospital in Linz, Austria. She comes with a wealth of experience in and around the neurointensive care unit, including different cerebral vascular diseases, primarily stroke and others. And today we'll be talking about the applications of transcranial Doppler within the neurointensive care unit. Additionally, we are also joined by Dr. Milan Voskov, who is the vice director of the clinical neurology, as well as the director of stroke at the Kepler University in Linz, Austria. And his specialties are in and around vascular neurology and neurosonology. Both are extremely well published and well researched in this area of neurocritical care and the applications of neurosonology. And we're very excited to hear the applications of TCD within neurocritical care. Today, I'll be moderating the questions. So if you have any, please enter them in the chat box, and I will be bringing those up at the end of the presentation today. And with that, I'd like to introduce our speakers again. Very excited to hear the applications of TCD within neurocritical care.
Thank you very much, Robert. So I try to start the presentation and to share our screen. I hope you can see the first slide, and we are very happy to introduce and to share with you our experience with application of transcranial Doppler in the intensive care unit. So, dear colleagues, best regards from Linz in Austria. We have the luck to have the own neurointensive care unit at our clinic, as well as a quite high volume stroke unit where we can apply the ultrasound in various manners. Here are our financial disclosures, and thank you very much to the company NovaSignal for giving us this opportunity, for inviting us to share our experience with you. And even if we get some honoraria, we are allowed to speak absolutely objectively and open and share our practical and scientific experiences with you. Let me introduce, just to share and to give you a quick overview about the procedures we are routinely using in our intensive care unit. And of course, I just very briefly, I would like to mention that the ultrasound help us dramatically to enhance the safety and success rate of punctures on the intensive care unit with the high level of evidence of A1 or A2, as you can see. On now going to the intracranially, we really rely on ultrasound as a bedside easy method and non-invasive method to measure midline shift and to detect soon elevating intracranial pressure. You see here the midline shift is this is a very simple method which takes a couple of seconds to measure and to indicate a soon decompressive craniectomy if it's needed. If we we can with the measurement of the optic sheet diameter, we can detect the increased ICP. And as you can see on the picture right below, if we have a polytraumatic patient with a head injury, who is edematous and swallowed, we even cannot open the eyes and to light to his pupil, but the ultrasound gives us absolutely elegant method to investigate his pupillary reflex, which we already recently published in the cooperation with Dr. Farina from Italy. And now I come to more known applications of TCD in the monitoring of vasospasm in subarachnoidal hemorrhage patients, because we think that these measurements should be done routinely and on a daily basis until there is no danger more for even late vasospasm. And there is a huge and really convincing data published on acute ischemic stroke, and we know that ultrasound and TCD may even predict the outcome after successful recanalization, but because we all know that not always after successful recanalization the flow in the periphery is not reach the values we would like to see, and this seems to be so these pathologic flows seems to predict a worse outcome in 90 days. And what is logical is the monitoring of multi-embolic signals to detect the patients at risk, and even to tailor the therapy in these patients to prevent multi-embolism. Already guaranteed and well-established diagnosis is the diagnosis of circulatory arrest in brain death patient. What we are really focusing on are the patients with traumatic brain injuries, because we treat 70 to 80 severe traumatic brain injuries in a year in our neurointensive care unit. So the theory is rich, but the practice is quite limited. So we are also keen to collect more data about it. But there are many data in pediatric detection, which says that with ultrasound we can even predict intracranial hypertension. But there is quite lacking data in adult population. And of course, then we have some special patients group like ECMO patients, which just came to our intensive care units in the last years. Even in our hospital, thanks to or due to COVID pandemia, the ECMOs really rise in our hospital. So from 2 machines, we have like 10 machines now, and therefore we are even collecting more experience with these group of patients. And of course, the sonography is absolutely helpful to monitor and to detect the effect of post-bypass surgery. Now I'm thinking on extra intracranial bypass to evaluate the effectiveness of this operation. And but of course, we know if we are dealing with ultrasound and TCD on intensive care unit, we are confronted with some limitations that this examination is operator dependent. There are even differences between countries and hospitals. For example, in many German ultrasonographic centers, assistants are performing the routine examinations, and there are even clinics where only physicians are doing it, and numbers of really well-trained physicians is mostly limited. Then, of course, we have to deal with some ICU setting. There is no much space around the patient. Challenging patients are the patients with head traumas, with a lot of bandages. And of course, sometimes to search for a good signal is not a matter of couple of minutes, but it takes time, and it, of course, then even personal and cost intensive. The important issue is the reproducibility, and I have to stress that I was really surprised last year when we did this pilot study, which Katerina will introduce shortly, that even thanks to robotic ultrasounds, the reproducibility seems to me to be much higher than if performed this examination individually. And of course, if on the next day another physician is performing the same examinations, examination, the values can even vary. And on the right side, in the right bottom, we see a device which so our center was also part of the Clotbuster trial. It was a trial with a neuro sonology or sonothrombolysis. And so it was the first large-scale attempt to produce a device which can give the ultrasound signal operator independently, but it was a therapeutic device, and we didn't have any feedback about the flows. So this was just a quite introduction to the feasibility study, and now I would like to ask Katerina to share our experience and to tell you about our practical experiences. Katerina, go, green light.
Thank you, Milan. Good afternoon, everybody. Well, as we just saw and as we know, the value of transcranial Doppler as a single shot examination is well established with just so many applications of it that Milan just cited, and also not in the intensive care unit, of course. But of course, the technique entails in itself the possibility of continuous data acquisition, just in itself being bedside and non-invasive. But however, this application so far has been limited because, as we said, it is operator dependent and time consuming and has some technical difficulties. So we try to overcome some of these issues by using a robotic assisted TCD from Novasignal, where, as you may know, the robotic headset automatically finds the transtemporal window and then, most importantly, allows us to track and continually follow the middle cerebral artery window signal, even if the patient slightly move their heads. So we evaluated the system in our university clinic in the general and the neurological ICU on a total of 14 patients. This was in October 2021 for a total of 22 examinations. As you can see, most of our patients came from the neurological ICU. We performed then bilateral middle cerebral artery monitorings for 30 to 60 minutes on average, and 1 or 2 operators were needed to set up the device. Most of the examinations was done by myself, Milan, and a colleague from Italy, Dr. Alvise Salimbeni. This is the patients from the general ICU. It was a total of 5 patients, 3 on veno-venous ECMO and 2 on arteriovenous ECMO. It is to be noted that we managed to perform the examination on all patients in spite of all the COVID protection measurements, and also, as you can see from the second picture, even in patients who had a lot of arterial, venous, tracheal tubes with some arrangements. In spite of all of this, the average time to find a transtemporal window was quite short. It was of 2 minutes, and we could find 90% of the transtemporal windows. Here you can see an example of a measurement of a veno-venous ECMO patients. This was a 52-year-old male patient with acute respiratory distress syndrome in a very advanced systemic lupus erythematosus. As you know, veno-venous ECMO is basically respiratory support where venous blood is drained from the vein, mostly the femoral, and is then oxygenated, and CO2 is removed and then drained again into the jugular vein and then into the right atrium. So it basically then brings to adequate oxygenation. In this patient, his problem was most importantly the CO2, which was then kept at almost physiological levels with the ECMO. And what we can see in this case was a patient which had what we can say is a almost physiological blood flow and pulsatility index. Actually, the cerebral hemodynamics on patients on ECMO machine is as good as unknown, and this can be of extreme relevance in the future for future studies, because actually the neurological consequences after ECMO treatment are not rare. They're reported to be in the literature up to 10 to 13% of the patient, even though we believe that the true rate is actually underestimated. Veno arterial, as far as the short-term outcomes, veno arterial ECMOs have more often ischemic stroke and hypoxic brain injury, and veno-venous ECMO more often present with a cerebral hemorrhage. There are also long-term neurological and psychiatric symptoms, and the prognostic predictors of these are basically unknown, and we believe that cerebral hemodynamics can be the key to find some of them. Then we come to our neurological intensive care patients. It was a total of 9 patients. We also could perform the examination on all of our patients. We can find the window, the transtemporal windows in approximately 3 minutes. And again, we can find 89% of the transtemporal windows. This is an example of 87-year-old man that came to our department after a suicidal attempt by strangulation. He was comatose upon admission with a Glasgow coma scale of 7. He had no structural pathology on his brain CT and CT angio, so he had no carotid stenosis and no traumatic dissection due to the strangulation. After 48 hours, in spite of no structural changes and no rise in his neuron, in his NSC, he was still comatose, and he suddenly developed a hypercapnia, which had no lung, which could not be attributed to any lung disease. And accordingly, we could see in his TCD then high velocities and a low pulsatility level that showed us that a reduced cerebral vascular resistance, which we could most certainly attribute to his hypercapnia according to the vasomotor activity loss. But again, also in acute brain injury, the dynamics, the development of this patient and the prognostic factors are unknown, and cerebral hemodynamics could be of extreme relevance for this patient. This patient then subsequently developed multi-organ failure and died shortly after this examination. This will be another example of a neuro ICU patient. This was a 74-year-old female patient that presented the day before with right-sided T occlusion of her intracranial ICA and middle cerebral artery, which was treated with thrombolysis and thrombectomy with operative very good recanalization. What we saw on her TCD, interestingly, was that she had a continuous microemboli signals on the right side, on the operated side, which we can see here in this video. So microemboli signal, as you may know, are these short, high energy transient signals that can be seen on the Doppler spectrum that have this characteristic chirp or a click sound. I will play this again. And they have been reported to be a surrogate marker for acute ischemic stroke, and that especially after endovascular treatment in anterior circulation ischemic stroke patients, they have been reported to be associated with poor prognosis. Although interestingly enough, usually they're associated with poor prognosis, and especially in patients with incomplete recanalization. And our patient had complete successful recanalization with double treatment, and she still presented with subcontinuous microemboli signal on the treated side. She indeed went on to develop intraparenchymal bleeding with mass effect and midline shift, and she became comatose. I will then show you her general TCD, so to say. So what we can see here is this patient had high pulsatility index of almost 2 on both sides, and low, especially low diastolic flow velocity compared to her peak systolic velocity. And these both factors combined, especially combined together, have been shown to suggest elevated intracranial cerebral pressure, which we knew that the patient was actually developing. This has not been validated, and there is a lot of discussion on what could be the best indicators of non-invasive intracranial cerebral pressure. but the most promising factors seem to be high pulsatility index combined with low diastolic flow velocity, which seemed to be the case also in our patient. And indeed, our patient developed then transtemporal herniation and died 48 hours after this examination. And the last case I'm going to show you is a patient with a traumatic brain injury and vasospasm. Vasospasm is an entity that we, of course, know for patients that experience an aneurysmal rupture and subarachnoidal hemorrhage in about 70% of the patients, but it has actually been reported for up to 40% of patients after severe brain trauma. The true incidence is probably actually a lot higher. And interestingly, that does not only occur in patients that have a traumatic subarachnoidal hemorrhage, but also in patients with subdural hematoma or diffuse axonal injury, because in the traumatic vasospasm etiology, there is not only the chemical part involved as for the aneurysmal rupture, but also the mechanical part of the trauma itself seem to bring to the etiopathogenesis of the vasospasm. What has been observed for these traumatic vasospasms is that they come before and they tend to last less compared to those of the aneurysmal ruptures. They come usually around 2 days after trauma, and they last in 50% of the cases less than 5 days. As far as prevention and acute therapy options, we have very few data. For prevention of traumatic vasospasm, there is a review on almost 2,000 patients that suggests that nimodipine could be useful to prevent vasospasm also after a brain trauma. But only one study on 224 patients shown benefit from treatment of detected vasospasm in this patient. How do we diagnose it? In this case, as we know, TCD is vital. And what we use are not only the mean flow values itself, because as we know, they can be influenced by many different factors. But what we do is measure middle cerebral artery, internal cerebral artery ratio, which is called the Lindegard index, which when it's elevated suggests the presence of vasospasm. The vasospasm can then be confirmed by angiographic findings and can then lead to ischemic changes or other neurological symptoms. So this is our patient. She was a 17-year-old female patient. She was attacked by an animal on her, by a ram on her own farm, and she experienced a very severe brain trauma with Glasgow Coma Scale 4 on site. And we can see that she had subdural hematoma as well as, of course, subcutaneous edema and hemorrhage, parenchymal hematoma on the temporal left side, and diffuse subarachnoidal components. So this was the first TCD that we performed on this patient on day 7. She was still sedated and intubated, hemodynamically stable. And we see that she had somehow elevated pulsatility index, but her flow values could be regarded as normal. The situation changed a lot after 5 days. We performed a control on this patient because our neurointensive care team decided for an extubation trial. She was extubated since 2 days. She didn't have any sedation since 3 days, but she still was comatose. Her EEG was not showing any epileptic activity. So we performed TCD and we showed that the mean flow values were doubled and pathological, and also her pulsatility indexes were still high. So we suspected, and we also performed the Lindegard index, which was around 4. So we suspected mild vasospasm, and we decided to try to do a trial of empiric nimotop nimodipine intravenously. It also of interest that since we decided to perform this therapy, we decided to do this under TCD monitoring to monitor for rush hemodynamic, cerebral hemodynamic changes. So in total, we perform monitoring of 2.5 hours of this patient, after which she developed temporal skin pressure lesions. But as you can remember, this patient also had very marked subcutaneous edema. So we decided to do a course of intravenous nimodipine on this traumatic vasospasm, and on the next day we could see that after 24 hours of this therapy, the values, the pulsatility was still very high, but the mean flow values and the Lindegard index consecutively were much better. So then we took the decision to try to stop the therapy. The day after, we can see on this image in the middle that the values after discontinuation of nimodipine got a bit worse again. And we did daily monitorings of this patient, and we saw that slowly the values returned to normal. And the patient then slowly regained consciousness, and this was were her final images. And could then be transferred to a rehabilitation facility. So this was my last case, and we then can summarize our experience. Please, Milan.
Thank you very much, Katerina. So allow me to summarize that after Katerina has showed you some representative patients and cases from our experience with robotic ultrasound, I still have in my memory that at the beginning we didn't need any half a day to cope with the equipment and to learn how to set it. And even what was absolutely impressive, that the time when the system has found the correct flow was between a couple of seconds until a couple of minutes. So it was really astonishing how reproducible the measurement was. So our pilot feasibility study showed that in intensive care unit setting, the robotic ultrasound was very safe and well tolerated and feasible method to examine with TCD. Sometimes some patient with head traumas and edematous could be challenging, and also this method was very reproducible and powerful instrument that provided a real-time continuous information about the cerebral blood flow in different acute settings. Even we think that that this method will allow to do more examinations with a longer continuous monitoring. And so we are really looking forward to more data and to perform more clinical studies in intensive care or neurointensive care patients. Thank you very much. And we are looking for your questions and discussion.
Well, first of all, I'd like to thank you for the presentation. The breadth of the applications is truly amazing, and really appreciate the in-detailed look at the applications of TCD within neurocritical care. There's a number of questions ranging in a number of areas, so I'm going to triage these as I can. One question came up regarding, it's more of a description of a patient. So Steve Knight asks, we have a patient in our cardiac ICU on ECMO. The EF is very low, less than 55, 5% VFib. Flow is continuous. Is there any data to retrieve what flow is not oscillatory? Can you read?
What flow is not? Acoustically, we couldn't hear the end of the question.
Is there any data to be retrieved that the flow is not oscillatory?
Oscillatory.
Mm-hmm. So representative, yes.
Yeah.
Pulsatile.
I don't think that we have sufficient data on a specific threshold. I'm just thinking about to see that there is a threshold for the representative brain death diagnostic, so that the patients have at least the blood pressure above 80 to be decision making or to make a decision making investigation. So, and this is again a reason why a robotic ultrasound can give us more information and collect more data, even in patients with under catecholamines and with blood pressure fluctuations.
And I understand that this patient is on ECMO machine. So on the veno-arterial ECMO machines we saw in the 2 patients that we saw, the flow was not pulsatile at all, but this has been described from the veno-arterial ECMO patients. So it has been suggested that some information will come from the amount of the oscillations that is retained in this flow, but these are all questions that need to be answered, because virtually all of the ECMO patients on the veno-arterial have this flow, but some of them develop the neurological consequences and some not. So the not oscillatory flow on itself should not be enough to say that this is a prognostic negative value, so to say.
Mm-hmm.
Great. I guess a related question on that, related to the use of TCD within ECMO, is it used really to optimize pump flow, oxygenation, and adequate perfusion when you're thinking about the applications of TCD within managing ECMO patients?
Where is the question?
Questions are coming in 2 different boxes. So the
okay. So we
yeah,
cannot see the questions. So
yeah.
So the question is can we use TCD to optimize perfusion settings on the ECMO, basically?
Yeah, and whether it's optimized pump for oxygenation or adequate, just overall adequate perfusion, how are you using TCD within those populations specifically for treatment decisions or management of those ECMO patients?
I mean, this is our all questions that we are asking ourselves, and we would like to know the answer very, very soon, because we really think that the answers could be in the cerebral hemodynamics. I think first of all, we need to find prognostic indicators for this patient, and then we can target that cerebral hemodynamics parameters as our outcome measures for the perfusion settings. But this is a lot of work to be done.
Yeah. Another question on ECMO. This is a hot topic. Someone asks, do you increase the patient's oxygen during TCD emboli monitoring on LVAD or ECMO patients to help evaluate whether the hits are clots or air bubbles?
Oh, that's an interesting
question.
This
is a very
actually.
interesting question.
Yeah.
So far, as far as I know, there are no known criteria that can help differentiate the nature of the clots. I mean, there is speculation, of course, on their energy and when they come in the cardiac cycle, but this has not been done so far.
Yeah.
What do you think?
Yeah, the same. So, yeah, we are really looking forward to collect more data about it. Then we have here one question. Given that you are collaborating with doctor in Italy from Austria, what's role of cloud-based data sharing in your practice? That's an interesting question, and I think this is the future. We were collaborating with Filippo Farina and Alvise Salimbeni from the clinic of Professor Barachini Claudio, our good friend and collaborator partner in Padua. And both these guys visited Linz to make some study and then return back to Italy. And we are continuing the collaborations. So we were not changing data about the cloud, but this is a future because we have another project, not ultrasound, but imaging. And this is also based on making measurements on the spot by the patient, sending the data to the cloud, and the doctor can, based on telemedicine decision, can see this data. But so we hope that we will start with this project next year. And but our IT experts are just in troubles, and they see a lot of troubles with the data security. But I hope that we will overcome it.
Great
See another question asking, is the robotic probe working properly with sitting up the patient or prone? So I can tell that we also tested the system on patients that came in our clinic. For example, for microemboli, monitoring for symptomatic and asymptomatic carotid stenosis. And some of those patients we were also sitting, so that worked all right. We didn't try it on prone patients, but I can say that, for example, we tried it in the cardiological interventional suite where patients had other positions, so they had very hyperextended neck, and they also moved a little bit during the examination, and that worked okay. So prone position needs to be tried, but I don't see a big problem with that.
Mm-hmm. The next question is, do you know a cerebrovascular data registry? Me personally, not. There are stroke registries. The world known was the SITS registry, and now the rescue registry within the ESO East project. And even the Austrian stroke registry is collecting some data about the recanalization, but no about the hemodynamics data. And at this point, I would like to invite interested colleagues to join the group of experts, which is called ER in Sono, or European Society of Neurosonology and Cerebral Hemodynamics, which offers a platform to build a network of these experts.
Okay, it looks like we had a follow-up question on how long does it take to clean the robotic probes after using it on COVID-19 patients?
So in general, we register also the time that it took us to take off the system from the patient. That was never more than 10 minutes. 8 minutes, I think, was the average. And of course, with the COVID patients, it took us some more time, and we just adapted the same protocol that was used for other devices, and I think this added for 5 to 10 minutes more in general.
Great. So we have another panel of questions as well. One is, are there any pediatric applications available?
Pediatrics, we don't have experience with that. We just did examinations in adult patients.
Another question about the long duration monitoring and applications. I'll expand this question a little bit about how did the robotic probes change the ability to do longer duration measurements, either for your study or in the future, as well as how did that impact some of the clinical decision making with the ability to do some of those longer term monitoring?
Would you like to start? Yes.
So I have to say, I also performed some studies with manual continuous monitoring, and I can say that, of course, the robotic assistant system is a very big aid, especially for the continuous monitoring, because even comatose or sedated patient can, well, of course, they cannot move, but something can slightly change with the respiration, with the machine. So basically, without the robotic assistant device, you always need to physically be there. And I would go as far to say that you all need to physically hold the probe all the time, 90% of the time. And of course, when it's awake patients, even more so. So this allowed for much longer and much more comfortable examination. We could go to the screen and make reflections about what we were seeing without having to worry about the probes themselves. So this allowed to do the 2.5-hour monitoring. And also I have to say, in that particular case where we decided to do the nimodipine therapy, which is basically not supported by any guidelines, and we decided to do an empirical therapy on that patients. The idea of having a live monitoring of the cerebral hemodynamics of these patients also supported us in doing so, because we could see the live changes, or the rapid effects of our therapy, and we felt comfortable enough to then stop it or not in case we saw something we didn't like. So that definitely helped us in our clinical decision in that case.
Then I see another questions. Are there times when using the robotic probe cannot be used because of neck brace, cannula, etc.? So actually, not in the intensive care unit. On the ICU, the only limitations are really fresh wounds in the temporal region. Once the region is good accessible for the ultrasound probe, the examination could be done very well. Where we saw these limitations was the operation theater. We wanted to monitor carotid endarterectomy, and then we conflicted with the surgeon because he needed all these regions to have a sterile, and then the construction of the device did not allow to monitor the procedure. So that was the only limitation we met.
Yes, and I would like to stress that for the ECMO patients, of course, at first it was challenging because they had especially the jugular cannulas, but with some cooperation from the nursing team, we always managed to perform the examinations. We had to move the cannulas a little bit, but we always managed.
Looks like there's another question on the use of the robotic TCD for static autoregulation testing.
Static, do I understand well that it is like outpatient department and the patient is just lying and cooperating with the test? So if it is this meant, I think we try so we did some study, and what we were nicely surprised is that the reproducibility of the like a breath holding test or other stuff was just more accurate than if done it manually.
Yeah, I think a follow-up to that was they are doing autoregulation testing within the ICU environment, and whether it's, I guess, dynamic or static, just tests on whether or not the autoregulation is present or intact. I think that's probably the origin of the question. So do you use autoregulation testing within the ICU environment?
To ability to go to surgery. Yes, so we actually also performing routinely and obligatory vasomotoric reactivity before surgery. And I hope that this will be cerebral vascular surgery or carotid surgery. So yes, we do it. Yeah.
On the other panel, we had a question about acute liver failure patients on whether or not you had studied any of those or the applications of TCD within that. I'm assuming for intracranial hypertension, but.
Or hepatic encephalopathy, I guess.
Yeah.
We did not have such subset of patients, but these are also patients where the prognosis can be challenging because, for example, the ammoniac levels are not a good correlation for their outcome, and sometimes it's difficult to find good prognostic values. So this could be a very interesting field of application for sure.
There's another question on post-mechanical thrombectomy monitoring. Some of the data, it's becoming a more important topic. It seems like over the last couple of years. Could you speak a little bit to the applications of the use of cerebral hemodynamics post-mechanical thrombectomy in the ICU?
Well, yes, it is actually extremely important to monitor this patient after thrombectomy because successful recanalization does not always equal successful reperfusion. So it has been shown by studies conducted in Italy and in Austria too, that the cerebral hemodynamic monitoring after thrombectomy is extremely important, especially the ratio of the peak systolic velocities between the operated side and the other side, because when acutely after a procedure, this is still very asymmetrical. This indicates for worse prognosis. So actually monitoring of this patient 24 hours, in the first 24 hours after thrombectomy can have very important impact on their prognosis and can have prognostic implications. So this is what has been known so far.
One thing is flow, and the another thing are microembolic signals.
Yeah, for example, our patient had like what could be regarded as a successful treatment. She had thrombolysis and then she had thrombectomy with a TC3 recanalization. But interestingly, she was still having continuously microemboli from the affected side. She also had paroxysmal atrial fibrillation, but she was having emboli only on the treated side. And actually emboli are more often seen in case of incomplete recanalization, but also, as has been shown before, the presence of microemboli after recanalization, even after a successful one, was a prognostic indicator for bad prognosis, as was in her case. So both the hemodynamics alone, so the velocities, and the microemboli should be monitored systematically after after thrombectomy, especially, or after recanalization therapy, I would say.
Yeah. So, a question on vasospasm and the applications of robotic TCD for increased monitoring. I think it's fairly standard that is once per day today. How do you see or the benefits or the clinical applications of increased monitoring using TCD for vasospasm? Is there a benefit there, and how do you see continuous monitoring of those patients?
Yeah, so definitely, I see a big advantage of robotic ultrasound system because it enables more comfortable application to the patient. It is operator independent, and as based on our experience, just if it's once running, it's the automatic robotic probe is adjusting even when the patient moves the head. So the measurement is reproducible and more easy. So even these facts already guarantee the longer duration of examination in comparison when the doctors or assistants are doing it manually. So I think this is actually an example of application.
Well, excellent. I think that I got all of the questions. If there are no more, I'd like to thank you again for the incredible work and the incredible overview of the applications of TCD within the ICU on not only stroke patients but TBI patients and others. This has been amazing. I'd like to thank you again for the time and the effort in going into this.
It was our pleasure.
Thank you very much for a kind invitation. Thank you for giving us the opportunity, to the Nova Signal company, and also to you, Robert, for a nice invitation. And thank you for all these questions. And if some of the colleagues would still have some questions on us, we will be happy to, if you will contact us, and so we can connect directly. Thank you very much. Good afternoon.
Thank you.
Good afternoon to you.